Good afternoon. My name is John Bryan. I work with the Florida Council for Community Mental Health. We are an association of 65 community mental health and substance abuse treatment agencies throughout Florida and are committed to the provision of high-quality mental health and substance abuse services to the citizens of Florida. I want to, first of all, say how glad I am to be here this afternoon and also to have this particular panel. When we were talking about our various kind of pieces, what do you want to present, what do you want to do, my interest was on a focus on community-based intervention and diversion for persons who are mentally ill and substance abusers residing in the community, and also a focus on the collaborative community-based efforts that are going on in Florida today that have demonstrated they can work and can serve as models for other communities throughout the state. And we've selected an excellent group of panelists here today. Gail Cordial is the Executive Director of the Florida Partners in Crisis. Cindy Schwartz works with the 11th Circuit Court out of Miami. Ann Arnall is with Lee County Government, is the Director of the Human Services Program, and Donna Weish, who works with Orange County in their Mental Health and Homeless Program. The reason that this particular issue is so important, I think, to us is that each year, over 2.2 million people diagnosed with mental illness are arrested and booked in jails throughout the United States. 3/4 of these individuals are also involved in co-occurring substance abuse disorders. On any given day in Florida, there are approximately 18,000 prison inmates, 15,000 local jail detainees, and 40,000 individuals under correctional supervision in the community with a serious mental illness. Annually, there are over 170,000 people with mental illness requiring treatment arrested and booked in Florida jails. This year, approximately 7,000 inmates with serious mental illness will be released from Florida prisons. A recent study has found that 31% of women and 14% of men being booked into local jails have a major mental illness. The challenge to this, frankly, is that these rates for women, their issues are compounded because typically they are treated in environments that are predominantly male and have histories of trauma, incarceration, homelessness, and hopelessness. Florida has really no strategic, comprehensive approach or systems of care in place in local communities to address this issue. But what we do have are pockets of excellence throughout the state of Florida. Several communities in this state have implemented strategies and programs that have successfully stopped the cycle of criminalization for persons who are mentally ill or substance abusers by putting in place programs and services that intervene and break this cycle. That's, in a sense, the group of individuals I want to introduce you to today. We're going to start with Gail.
I don't have a PowerPoint.
No? Okay, right.
Good afternoon. It's my pleasure to be here today to talk to you about the reinvestment grants. What I'm going to do is give you a little bit of a history about the grants and point out a couple of the components that I think are really what have made them successful. And then these ladies are going to give you what you're really here for, which is to see the success that they've had with the programs. Florida Partners in Crisis was founded more than 14 years ago when Judge Belvin Perry and Sheriff Don Esslinger got together to advocate for more community resources for people with mental illness and substance use disorder to keep them out of the jail and out of their courthouse. While their efforts were successful in bringing home the bacon that we all seek when we go to Tallahassee, we knew that just having financial resources really wasn't the solution for this population. Our mission at Partners in Crisis is to help communities build systems of care through partnerships between criminal justice and the behavioral health system. We want to understand the role of each of those partners from the very first time that law enforcement gets the call, through the court process, and into reentry into the community. Without those linkages in all of the different intercept points, you're really not going to have a successful program. So in 2006, our members drafted legislation called the Criminal Justice, Mental Health, and Substance Abuse Reinvestment Grant Act. It's section 394.656 for those of you who are interested. The reinvestment grants, as they are known, were patterned after the federal Majorca grants, the Mentally Ill Offender Treatment and Crime Reduction Act. And unlike many reform bills that we see in Tallahassee, this one actually did get not only a hearing, but it passed during its first session in 2007. And I'm going to read to you what the statute says because I think this is important and it's brief. The purpose of the reinvestment grant program is to provide funding to counties to plan, implement, or expand initiatives that increase public safety, avert increased spending on criminal justice, and improve the accessibility and effectiveness of treatment services for adults and juveniles who have a mental illness, substance use disorder, or co-occurring mental health and substance use disorder and are at risk of or are in the criminal justice system. And as John said, I don't think it would surprise anyone in this room to know that nearly 80% of the people with mental illnesses in our jails also have a co-occurring substance use disorder. So public safety, appropriate spending, and access to treatment. The grants are unique in that every applicant, and the counties have to apply on behalf of their community, every applicant has to demonstrate a well-established collaborative plan that includes public-private partnerships and the use of evidence-based practices. And they have to be able to match their grant 100% to demonstrate their commitment. While the statute is prescriptive with regard to partnerships and funding, it's flexible in that it allows the grantees to determine the program that's best for their community. And I think this is what helps to make them so effective. You have to have everybody at the table before you can start the process, but you get to choose what works best. The types of programs that can be funded include mental health courts, diversion programs, crisis intervention team training, housing and supported employment programs, and reentry services. So how much money are we talking about? The statute allows for two types of grants, the one-year planning grants and 3-year implementation grants. In 2007, there was a total of $4 million that was appropriated, $1 million for planning grants and $3 million for implementation grants. That year, 12 planning grants were awarded and 10 implementation grants were awarded. However, in 2008, when the state began to experience budget troubles, that number was cut to $3 million. And since then, we have not had any planning grants, only implementation grants. During the second cycle, because the grants are awarded in 3-year cycles, in 2010, 14 counties received grants. 5 of those counties had existing programs from the previous segment, then they received $250,000 each for the 3 years. And there were 9 additional counties that received new funds of approximately $180,000 for 3 years. And finally, last week, the third round of grants was awarded to 8 counties, and the average is $400,000 each. So if you take the $400,000 and you add the matching funds, that's $2.4 million for each program, a total of $19.2 million over the 3 years for new initiatives that we desperately need. How about the accountability and oversight? The program is administered by the Department of Children and Families, but the original legislation also created the Technical Assistance Center at the Florida Mental Health Institute at USF. The TAC assists counties with a number of functions, including data collection and monitoring the effectiveness of their program, and they also prepare an annual report to the governor and legislature. The center also serves as a comprehensive clearinghouse for information and resources related to criminal justice, juvenile justice, mental health, and substance abuse. Each of the counties here that are represented today were awarded reinvestment grants in both the 2007 and 2010 funding cycles. As you'll see from their presentations, they've used their collaborative strengths to not only leverage additional funding sources, to bring new partners to the table, to affect change in their community, but most importantly, to help people maintain their recovery and their wellness, which is really the key to reducing recidivism. I think you'll agree after you hear their presentations that they validate the creation of the reinvestment grants, and I think they clearly demonstrate the reason why it's time to expand and increase funding for the grants. So thank you, John.
Let me introduce Cindy from Dade County Courts.
Hello, everybody. How are you today? My name is Cindy Schwartz, and I'm the project director of the 11th Judicial Circuit Criminal Mental Health Project in Miami-Dade County, Florida. And I'm going to be talking to you today about how we developed a specialized entitlement unit to help people to get Social Security benefits. The clicker? The clicker, the clicker. Okay. So our program was developed as a jail diversion project. And it was designed and implemented to divert people with serious mental illnesses away from the criminal justice system and into community-based treatment and services. I just want to give you a brief background. We have a pre-booking diversion program. We have a CIT law enforcement training. We have trained since 2003 more than 4,000 police officers. So that has had a huge impact on how people get diverted before they even get arrested. We also have a post-booking project. We serve people that get arrested for misdemeanors and identified in the jail as having psychiatric illnesses. We have a felony program. Entrance into that program is a little bit different, but I'm not going to get into that today. Oh, but what I should tell you is that our felony program was developed as a reinvestment grant. So that's where we started with the reinvestment grants. Our felony program started, I think, in 2006, and 2009 was sustained by the court system. I work for the Administrative Office of the Court. So our felony program was sustained because it proved to have such tremendous results. But that's not why I'm here to talk to you today. I also want to tell you before we go forward that we receive funds from the Department of Children and Families to our managing entity to provide interim assistance with housing, medication, treatment, and any ancillary services. So today I'm going to be talking about what the problem is. We know that people that have severe mental illnesses need to be able to move towards self-sufficiency. They need to be able to meet their basic needs when they're being released from jail. If you have no money and you have no health insurance, the bet is that you will come back into the system very soon. So we wanted to help our people to apply for Social Security benefits. And we wanted to close that revolving door of homelessness and incarceration. But we know that the Social Security process is very difficult to make an application, especially for people that are homeless. So only about 37% of people across all disability groups are approved for Social Security on the initial application. Well, what does that mean? That means that 63% are denied. And there's a common myth that when you apply for Social Security benefits, you will be denied at least 2 or 3 times. So we decided to go at this in a very strong way. What we decided to do was to utilize a method called SOAR, and that stands for SSI/SSDI, Outreach, Access, and Recovery. This was an initiative that was begun by SAMHSA as a technical initiative, assistance initiative, to help people that were homeless and chronically mentally ill. So we thought if we jumped on that bandwagon and we started to help people to apply for these Social Security benefits, that we would be able to help the people that were re-entering the community from jail. But in order to be approved for Social Security benefits, you need to have adequate assessment and documentation about how your disabling conditions limit your ability to work. The eligibility for Social Security is that you have a documented illness and that you have functional limitations that impede your ability to work. So if you go into jail and you say to anybody, do you have a way to support yourself when you get out? Many people will say no. And if you say, well, we could help you, everybody will say, yes, I want a check. But the thing about it is not everybody is eligible for Social Security benefits. So that's very important in terms of the success when you're applying for people. So you need to have staff that understand what is the process, because for anybody that's going to Social Security, you think you fill out the application, you hand it in, and then some mysterious process goes on behind that window that nobody seems to know what it is. But we train our staff to know exactly what they need to do in order to submit a successful application. We also have developed relationships with Social Security, the State Disability Determination Service, community medical providers, and so many other community partners that are essential in changing these outcomes for these Social Security applications. How many of you have helped anyone get a Social Security application through? Anybody? And what's your basic knowledge? That it takes 6 to 9 months to get somebody approved? Is that what common knowledge is? If you're lucky, it takes 6 to 9 months, right? If you get approved at all. So we came up with this innovative plan to use SOAR to access and expedite Social Security benefits. We screen all of our jail diversion participants to see if they are eligible for Social Security benefits. The people that are eligible, we will provide the assistance. We'll do it as soon as possible, and we will use that interim money that we get from the Department of Children and Families to bridge the gap. So anyone that is re-entering the community from our jail diversion program, we will help to get housing immediately. We will get them treatment immediately, and we'll make sure that they're taking medication as soon as possible upon release from jail. So those are the things that we do in the jail diversion program. One of the best things about this approach is that I was able to go out into my community and market the service providers about what a great deal this was. I said, these people that are coming out of the jail diversion program are potential attractive paying customers. So I was flipping the script and telling them these are not just poor, disenfranchised criminals with mental health problems. I was saying that if they worked with us and we did the application for Social Security, we would get them to be attractive paying customers, and they would be able to retroactively bill Medicaid 90 days retroactively from the day of the application. So when we first started this project, I went to Jackson Memorial Hospital, who is our large public hospital, and I counted up all the facts and figures about how many people were leaving the jail and going straight into the hospital. And I said to them, you may be able to recoup about $800,000 a year if you partner with us on this project. Well, what do you think they said? They said, sure, we'll do it with you. $800,000 is enough money to say, sure, we'll give this a try. So this is really very exciting, and we really made it work. And one of the things that we discovered was that our case managers, our court case management specialists, really didn't have the time to be doing these intensive applications. So we applied for a reinvestment grant to make a special entitlement unit that would just apply for Social Security. And we expanded our target population to include not only our jail diversion program, but to include people that were identified in the jail that were serving a sentence. We also expanded it to the state attorney and the public defender if they had identified anybody with a mental illness that was being released to the community that may not have fit the eligibility criteria for the jail diversion programs. We're currently collecting our program data for a program evaluation, and I hope that we'll be able to present that material at the Florida Partners in Crisis Conference in July. We think that it's going to be really good. So our staffing for this project is 3 full-time staff. These 3 full-time staff engage the program participants, interview them, assess them, and serve as boundary spanners because they have to be able to work across the community to collect all types of medical documentation to make a successful Social Security application. We also have 2 part-time peer specialists because those people provide the support to our program participants, and they also help with assistance with access to community services. Now here comes the drum roll, guys. These are our results. To date, from 7/1/11, that's when we really started the program, to 12/31/13, we screened a total of 414 people. We had 188 applications to Social Security. There were 176 that were approved on the initial application. 176, which makes it a 94% approval rating. I'm sorry, this is phenomenal. This is really phenomenal because we are, but wait, the better news is that we do it in 28 days. So what we're really doing is we're flipping the script, we're turning things around so people can meet their basic needs when they re-enter the community. They can move towards self-sufficiency. They have access to housing, to food, and to medical care. The catch-22 for so many people that are being released from jail is that they have no access to medical care because they have no health insurance. So we are flipping the script, and we are connecting them in a very timely way so that they can move towards recovery and they can move towards successful community reintegration. And this also, let's not forget, this also helps us to reduce stigma. If you can take care of your own basic needs and not be identified as a poor, sick criminal that has a mental illness, but now is someone that has health insurance, can access housing, can live successfully in our community with supports, that's what really counts. So there are also financial benefits here. The approval rates far exceed the national average. We do it in about 1/10 of the time to decision. We maximize our use of state funding so that we can serve even more people with that limited amount of money that we get from DCF. And it leverages, we figure, about $33,500 per individual served in state-funded treatment and support. And what that means is that we are having access to approximately $5.9 million annually in state-funded equivalent services. And what I mean by that is once a person gets onto their Social Security and they get the resulting Medicaid, it's not just the state paying with these contingency funds. It's the people paying with their Medicaid and paying with what they have available to them. So we think that this is pretty phenomenal. And I must tell you that in my career, I think that this is one of my biggest accomplishments, helping people to move towards recovery on their own steam, getting them what they need so that they can move towards recovery and community integration. So, in summary, focusing on expediting benefits really does work. It's a win-win for the people that we serve, and it's a win-win for our communities. It's a major tool in community reentry and recovery. Thank you.
Thank you, Cindy. Next, we're going to hear from Ann Arnall from Lee County. Ann, thanks.
Good afternoon. I'm going to take a few minutes to talk to you about the Bob Janes Triage Center and Low Demand Shelter. Like Cindy mentioned, we have several different diversion type of things going on in Lee County. We have some post-arrest diversion things, drug court, mental health court. We've had a strong CIT program for law enforcement for many years, but what we didn't have was a place for law enforcement to take people once they encountered them on the street and realized somebody was ready to impact some change in their life. So we started with we're ready to start, and came up with a model before the criminal justice grants came out, so we were ready to go for the implementation grant when it came about. And what we did is we developed a pre-arrest diversion program that allows law enforcement to divert individuals for low-level offenses at the time of interaction with them. So think about a primarily homeless population that they're interacting with, trespass, open container, drunken, disorderly, individuals that were cycling through our criminal justice system on those type of offenses, primarily due to their lifestyle. So they were at ongoing high risk for rearrest, and also predominant or high percentage had substance abuse, mental illnesses that they were dealing with. It is a voluntary program, so it's voluntary on part of law enforcement to divert. So if there's warrants or other things going on, they're not going to divert people, but it's also voluntary on part of the individual. And probably the biggest thing or success for us is it gives that officer the ability to seize that moment when an individual says, I'm here because, and they start telling their story. That officer can, if they hear some motivation or desire for the person to change, they can say, we can get in the car right now with your bicycle, with your backpack, whatever you have, and I can take you somewhere that somebody will talk to you right now to get that help. In the past, law enforcement would try to engage people or hook them to services, but they were finding waiting lists at detox center, couldn't get into mental health treatment, things that you all encounter with that long wait. So the likelihood that you're going to find someone 3 weeks later, if their name comes up on the waiting list, is slim to none, and that they're going to still be motivated to go is pretty unlikely that they would go. So predominant population is homeless with substance abuse and mental health issues, but we work with them to then find meaningful solutions and engage them in treatment. This was done as a collaboration. The county is the lead agency. We had to be the grantee and apply for the grant, and it was really formed in partnership with law enforcement and those CIT officers or the leaders, but at the urging of a county commissioner by the name of Bob Janes, who was very engaged at the local, state, and national level on dealing with issues that impact the jail differently, and he was passionate about helping people who have mental illness or substance use disorders. So that's how I got to be involved, but we also brought our community mental health and substance abuse provider to the table. We fund them as a county, so that, carries some weight when you ask people to come engage with you, but our hospital system also came to the table, all our law enforcement, NAMI, we have a mental health probation officer there, so we brought this team of people together because they were the ones that worked predominantly with this population, and the Salvation Army is our key partner in running the shelter component because they run most of our homeless services in Lee County. The partnership with law enforcement, I mentioned we have the crisis intervention training, but we did not have a no refusal place to take individuals when law enforcement interacts with them. We follow the Memphis model, and their model has a 24/7 no refusal place for law enforcement to take people. But that officer is the key catalyst to get people off the street and engaged in treatment. So 71% of the referrals come from law enforcement officers bringing people directly to the facility. Our other partners, because our health system came to the table, our hospital system, we pretty much have one hospital monopoly in our county. They came to the table with some funding for nursing assessments, and they also wanted to be able to divert some of the same clientele from inappropriate utilization of their emergency room. So people were going to the emergency room, mostly are a very similar population, going to emergency room for primary care, or they could be going to the emergency room for drug-seeking behaviors. So when they found out it was non-emergent, they have the ability to divert people to the triage center. And the third way is our Veterans Administration a couple years ago came to us and said they wanted to make direct referrals to the triage center also. We were seeing homeless veterans that were coming in through law enforcement and through the hospital, but this gave the VA the opportunity to directly refer people that their homeless outreach workers identify and work with, and they have started paying for some beds in some of the per diem for the operations of the triage center, so they've become a partner with us. We do not have a veterans hospital in our area or a homeless shelter. We do have a governing board that has been meeting since inception. It's all the key partners. It's an imperative part of this collaboration that we communicate on a monthly basis, talk about what works, what doesn't work, strange things that come up. Those three ways to get in are law enforcement, hospital, or the VA. We do have judges from time to time that will try to court order people. We have homeless advocates that, get very upset that homeless people can't just walk in themselves. So at those monthly meetings, we counter things like getting people court ordered to the triage center and realize we need to go back and do some education and things like that. But we all meet on a regular basis and work on improving the program or anything that needs to be worked on. Upon admission to the program, people are coming in to get their basic needs met, so they're getting off the street. So the first, step is to get them their belongings brought in, get them checked in. We've made that commitment that we will not turn law enforcement away, which is why we can't allow walk-ins. We're a 58-bed facility. We cannot allow walk-ins, but during that assessment time, the first thing is a nurse assesses them to make sure they can safely stay. When we say low demand, people can be intoxicated when they come there. So that nurse is assessing, whether they're more of a detox candidate, but majority of people stay there at the center. She does that immediate nursing assessment. Then, of course, they get fed, showered, and so on, but within the first 24 to 48 hours, they get an in-depth psychosocial assessment. We are on the campus of our community mental health center. Actually, our mental health and substance abuse center just merged, so we've been on the campus of mental health since day one. They have staff that come in and do those assessments, and they start talking to people about setting goals. Could be they just need to get their ID and start reconnecting with benefits that they lost. It just depends on where they are, what kind of benefits they've had before. But as long as people are willing to work a plan, set some goals, they can stay there. It's an indefinite length of stay. It's intended to be short-term because it's there to be that linkage to treatment services, more appropriate supports, supportive housing, so we don't intend for people to stay long-term, but the average length of stay right now is 21 days for non-veteran and over 40 days for veteran population because the VA is providing some in-depth supports for them. We're seeing a high rate of people with no insurance, 38% self-report a mental illness right when they come in, 35% report substance abuse. We know it's higher than that, but remember, it's somebody telling someone they just met what their problems are, so that's underreported. 94% are homeless and 81% are without any steady source of income. 60% of the people coming in have a prior arrest record in Lee County, so that's showing that cycling through. When people exit the program, a good exit is defined that they are engaged in some kind of services or treatment or housing. So in the 5 years we've been operational, 46% of clients have had a good exit from the program. May seem small, but remember, we're very short-term in nature, and we're working with a primarily chronic homeless population that have a lot of barriers to overcome. We do not have we're extremely flexible. It was designed to be flexible, so there is not a maximum number of times people can come. So as long as they're making progress, they can stay working their plan. If after, a couple days they say, I really don't want to do that stuff, then staff will say, well, there's the door and the bus comes and you can move on and come back later if you change your mind. But we are very recovery-oriented in realizing that people are not going to recover from mental health or substance use disorders many times on the first time that they try. So they may try a little bit, relapse, go back out, they can come back if they're willing to work. In the first 5 years, we had 2,100 unique individuals come through the doors 3,700 times, so that shows you that, some come back 2, 3, 4, 5 times. Actually, we did some looking at data, and we had some real good results on several people, like on their 5th try. For whatever reason, it took them multiple attempts to get linked. We are connecting people with supportive housing, substance abuse and mental health benefits, and also income benefits. Success rate is clearly tied to the treatment capacity going out the back door, so getting them linked to those services, and Florida is a pretty poorly resourced state for mental health and substance abuse treatment. But we do follow some of our best practices. We follow sequential intercepts that people can come in through multiple ways. We are recovery-oriented. We include peer mentors there at the facility. We're collaborating with these other stakeholders in providing those program linkages. And we're using a housing-first model in many cases where people are leaving this facility and going directly into housing. A couple other things, we used existing resources in our community. The building was there. We used that infrastructure. We never would have been able to get this up and running. And we also use our homeless management information system, which is a client database that's required if you get federal funding for housing. The types of crimes that we target are very low-level offenses that I mentioned, which were trespass, open container, but you see on the left is 2003 to 2008 before we opened, the number of arrests and citations of those specific offenses, and then the numbers post-opening. So we've seen a 46% reduction on those actual offenses, and equate that to about $100,000 saving per year just on the jail costs, not on any of the court booking costs that we're realizing. Our funding, the match, as they mentioned, providers or communities have to at least equally match the grant. So our match was 28%, the grant was 20%, the VA is now providing 21%. We get a burn grant from FDLE, we get emergency solutions grant, we get some FEMA money, and the county funds it. So my one wish would be I had one funding stream to answer to and not that many in reports, but that's the way things go these days. Our efficiencies were that the wide array of services are available at one central location with multiple access points. Salus Care is the community mental health substance provider, is there with their intake center. The likelihood of people engaging in services has been better than them figuring it out on their own. We have different perspectives of the partners at the table, and we are able to then formulate better methods for program operation and treatment. And the community impact has been, in conclusion, that we're able to build a safer community, we're saving taxpayer money, and most importantly, is we're making a difference in people's lives that probably wouldn't have had that opportunity if law enforcement hadn't engaged with them in a different way. So thank you.
And thank you. We will have an opportunity for questions at the end for all of our panelists, but we'll hold off now and hear from Donna from Orange County.
Good afternoon. I love being the last presentation as you've been sitting all day. But this is Orlando, and it's either I-4 or 436, so don't be in a hurry. It's always a great opportunity for me when I get to brag about Orange County and some of the things we've done around substance abuse and mental health and receiving. Our CRC actually grew out of a crisis in our jail, and you know, when you have challenges, there usually is opportunities. So we took that opportunity, and the CRC was actually one of the major recommendations of the Jail Oversight Commission that came in about 12, 13 years ago to study our jail. So what I'm going to do is talk to you a little bit about the CRC system of care, but where the reinvestment grant comes in for us is really in our Phase 2 CRC project. So this is how our CRC system of care actually works, and we have a very active CIT training program. So our law enforcement officers are really the key, because what used to take them 2, 3, sometimes 4 hours to intervene with someone in crisis because of their substance use or mental health disorder is now taking them an average of 7 to 11 minutes to drop them off to get back on the street. So that's been very, very helpful for us in our community. So we've been operational almost 11 years now, and it's a central point of access that operates 24/7, 365. It's both Marchman and Baker Act receiving. And that's just a little bit of the data that we're seeing. When I wrote the initial white paper to the CRC, I wrote several different phases in it because I had an idea that we were going to need some case management, I had an idea that we might have some homeless individuals coming in. So we made some plan for what we might do in later months or later years, and the reinvestment grants have really helped us get there. So as with a lot of folks here, and Ann is a prime example, in getting your law enforcement officers involved in that pre-booking diversion so they never hit the jail, because what we saw from our Jail Oversight Commission is that tons of people were in our jails and suffering from a serious mental illness or substance use disorder. And as we know, our jails and prisons have become the de facto mental health receiving centers. So we were trying to prevent that. So to date, we have saved many, many, many jail bed days, and that could save tons and tons of money, as you're well aware. And our savings to the clerk and to the courts, we have no idea because those people aren't hitting the judge's dockets. But we do know that you can put a price tag on that. So our community hospitals also have been impacted because in Orange County we now have a transportation waiver because, you know, law enforcement officers are required to take to the nearest Baker Act receiving facility. And now our law enforcement officers bypass all those other receiving facilities to come to one central one central location, which allows us to do a number of things. It keeps people in the right resource because we know when someone needs to go to a substance use program or when someone needs to go to a CSU. We also know that if that person gets out of that institution, then where do they need to go next? Because a number of those folks are homeless, and there's an opportunity for us to make a plan. By bypassing the hospitals, it saves time, it saves a lot of money for those hospitals in defensive medicine, and it keeps people in the right space. Our CRC funding basically came in the first few years from the hospitals partnering with us and Orange County government. And then we were able to let our legislature know that we had a serious crisis in Orange County. We were one of the lowest funded districts in the state at that time, probably still are since there's been no new mental health money. But they saw the error of their ways only for a couple of years, gave us some additional funding, which helped us really rework our system and put things in place by using some of the Orange County dollars, which were more fungible at the time, and then replacing the state dollars with beds and things of that nature. However, in '09, that all went away. And so, thankfully, we'd done a really good job with data so that when we came to the mayor and the county commissioners in that year, they funded the $2 million to be able to keep that program going. But it's because of the kind of data we were able to capture at the CRC, it made that argument very easy for us. So some of the additional projects that we've done is our care coordination program, because we know that beds aren't always the answer, but being able to have community treatment that keeps people from utilizing those beds and keeps people in the community and in their housing. So we've been able to actually keep folks out of those deep-end services by using a care coordination program. We partner with both the Center for Drug-Free Living, which uses a different kind of model, case management care coordination model, and then Lakeside Behavioral Health Care that uses a different kind of intensive case management model. This is where our reinvestment grant came in. We opened the CRC Phase 2 program in 2008. And we did that because we kept watching the data, and consistently 20 to 27% of the folks who were coming in reported that they were chronically homeless. Now, they weren't only chronically homeless, they had a co-occurring mental illness, pretty serious mental illness with a co-occurring substance use disorder. So we knew that those were the folks that were, what? Hitting our jail, hitting our emergency departments for their primary health care, going through CSU, going through detox, and using all those systems. So what we started doing as a group was identifying what we all in here call those high utilizers or frequent flyers. And we noticed that there were 40 of them. And so little by little, our care coordinators would start engaging them. And more, we knew we had to do something, which was Phase 2. It is a transitional housing program. It will treat only those folks who have been through the CRC that have both of those disorders. So that's how the system works now, and we add our CRC for Phase 2 program. The average length of stay in this program is about 3 to 6 months, and the goal is, like Cindy, to get those folks on their disability if we can, and we use the SOAR method. Cindy's been amazing to come here and train a lot of our professionals to do the SOAR method. And then, of course, we want all of our folks to lead into permanent supportive housing, because that clearly is the end to homelessness. So this is our program. It's a 36. It started out as a 44-bed facility, but through budget cuts and losing one of our partners, it is now a 36-bed transitional housing program. And I don't know how many of you are in continuum of care communities, but you know that transitional housing programs, HUD is not really interested in funding any longer. So we're going to have to work to plan on some more permanent supportive housing in our community. So we're seeing about 98 participants a year. All are voluntary. So once this individual hits a CSU or hits a detox unit, those therapists need to start becoming salespeople to try to get those people from that unit onto this unit. So the components of the program, obviously, just like we said, getting their benefits or getting back to work or getting back in school, vocational training, etc. These are all the components of the program. The things that we've been able to do with the reinvestment grant is really add more clinical services, more mental health interventions, more substance abuse treatment, more housing. We added a housing specialist and folks that will follow them further into the community to make sure that they're set. We have great partners We have a healthcare center for the homeless that's provided the health services. We have Goodwill Industries. We have a number of people that are in and out of that program. But without the reinvestment grant, we would not have been able to add those clinical services. This is a tough population. As many of you know, the chronically homeless with these disorders are a tough population, but we are housing 63% of them, which I think is an amazing outcome for this group of folks. They're not using our intensive services as much. The disability applications, we're not doing as well as we want to, so we'll continue to work on that, and we'll get Cindy down here to do some more training for us. But that's it for us, and I'm happy to answer any questions when John starts taking questions. Thank you.
Thank you all very much. Questions for panelists? No? I know each of these folk personally. I know if you walk up to them during the course of the next several days, pose the questions, I'll be more than happy to talk with you. They are very proud of the work they do, and we're very proud to be associated with it. So thank you all very much, and have a good rest of the evening. And thanks to the panelists.